Thank you all for joining us today. My name is Rebecca Kiesling, and I am the Managing Director at Benjamin Rush Institute. We are happy to be welcoming you all back to our virtual event series, which we started in response to the COVID-19 pandemic. When medical schools closed, we really wanted to continue our education of students and just expand that to our network of supporters as well. We've had just a wonderful response to these, both live, but also on our YouTube channel, which this video will be recorded and be put up onto our YouTube channel, which you can search for and hopefully subscribe to. I'm really excited about today's speaker. If you're not familiar with the Benjamin Rush Institute, we are over 10 years old, and our mission hasn't changed since the beginning. We are dedicated to the education of medical students on free market healthcare alternatives. So many times what that education starts with is direct primary care. And I love direct primary care. I love the physicians that start direct primary care practices because I think they're very brave. Talking about how to take insurance and take bureaucracy and take the big government that is just stymieing that doctor-patient relationship and that is hindering that doctor-patient relationship and taking it away. It's very brave, and it's what is those physicians is what's going to help us get back to the way medicine is supposed to be practiced. But not every medical student and not every physician is going to be practicing primary care. There are a number of specialties, as we all know, that are out there, and it's physicians that are doing things a little bit differently and doing direct care that is not primary care. That is exciting to me because I want to be able to show our students that it can be done. And our guest today is one of those people. Diana M Granita Md Phd is a board certified in rheumatology and internal medicine. She completed a PhD in immunology and a postdoctoral fellowship at Harvard University, immunology fellowship at University of Pittsburgh, and rheumatology fellowship at University of Cincinnati. You'd think she really likes the cold, don't you? Wait till you see the view from where she is right now. She is founder and CEO of Rheumatologist OnCall, a direct specialty care telemedicine practice focused on broadening access to rheumatology, actively seeing patients in 9 states. Dr. Girnita graduated from the nutrition science course from Stanford University and a mindfulness course from the University of Massachusetts. She was recognized with the Top Doctor Award and is frequently invited speaker of the US National Arthritis Foundation. She is also the co-founder of the Direct Specialty Care Alliance. This is an organization that will lead the movement of specialists in becoming independent and provide direct care services to patients. So important. Dr. Girnita is also the co-leader of the FMMA California chapter. And if you're not familiar with the Free Market Medical Association, I hope that you will go look them up. I got the chance to meet and speak with her in person. I think she's phenomenal. And I love what she's doing, and also people that are part of the Direct Specialty Care Alliance. I think this is what we need to speak more to. And I think that medical students that are listening today, I hope that you will take a listen and look up the Direct Specialty Care Alliance, because if you are not interested or not looking to go into primary care, this is another option for you. So I'm going to turn this over because you really don't have an interest in listening to me all day, as we all know. I'm going to turn this over to Dr. Girnita. Please ask questions. You can ask them here on Zoom. You can text them to me or email them to me, students that are streaming this in from our chapters. And if you're listening in on Facebook, please go ahead and type those into the chat, and we will take them all. And after Dr. Girnita's presentation, we'll get to those. So thank you so much, and I will turn this over.
Rebecca, are you able to see me? Hi, everyone.
I am. You're okay.
All right. I'm very happy to be here. I'm delighted to give a talk to young people that are preparing for their career in medicine. I think it's extremely important to know about your options from a very early stage in your career to plan things accordingly. I am a specialist, as Rebecca mentioned, and I'm doing rheumatology at this point. And the practice that I started almost 2 years ago, it's a direct care practice. I'm going to talk a little bit about the future of specialists in direct care. And as I understood, you're all very well aware about the direct care, direct primary care movement. So today, you're going to hear a little bit about what's happening in the specialist world. So I'm going to share the screen. And we're going to start the talk. I would like to make a couple of points. If you look at our expenses in US in the last 20 years, between 1998 and 2020, we are definitely able to buy more computers, more TVs, more cars, or newer cars, and we can afford to pay for cell phone services. But more and more, we have to pay for medical care services and especially for hospital services. Those expenses increased to more than 200%, and the wages did not follow that trend. If you look at the healthcare costing on both the worker contribution and the employer contribution, the prices increased tremendously between 2009 and 2019. But again, the wages did not increase accordingly. So we pay more and more for the healthcare costs, but we receive less and less. Let's talk a little bit about what's happening in our days in the traditional healthcare in the patient side. On the patient side, we see higher costs, we see longer waiting time, less and less access to specialists. And on top of that, we pay co-payments, we pay higher prices for labs, imaging, and medication. And not very rare, we do receive surprise bills that will sometimes be shocking. On the physician side, on the other hand, there is less time spent with the patient and more time documenting into the electronic medical records. We get less and less reimbursement. We get no control on the patients that are sent to us or on the costs that we send to patients, and less control on our schedule. So you both know that both the premiums and the deductibles have increased tremendously. But the question is, do we have a better access? Do we have transparent costs? Do we know where this money are going? And who benefits from the increase in this cost? That's the big question. When I look up the number of specialists in the United States, in 2019, there were about 900,000 specialists in the United States, but some specialties like mine, rheumatology or allergy or pulmonary or thoracic surgery or neurological surgeries are not very well represented. And when we go to the pediatric side of specialties like cardiology, hematology, or critical care, the numbers are looking even worse. So what's happening? The patients will wait much longer to see a specialist. This is a graph that I was able to find from 2012, but those numbers did not actually improve at all. On the other hand, they did look much worse if you look in the data of this year's. So if you need an allergist, you know, probably the average waiting time is going to be about 60 days. If you need a gastroenterologist, the waiting time will be about 100 days. But what happens if you see a rheumatologist? You're going to wait in average about 90 days. So in order to accommodate more and more patients, the load of patients per specialist increased tremendously in the last 20 years. So in our days, a specialist is expected to see between 20 and 30 patients a day. And those numbers will not improve. Those numbers of physicians will be less and less because there is a real shortage of physicians, not only on the specialists, but also on the primary care side. And the numbers will increase tremendously in the next 10, 15 years. The Medicare population is also increasing, and the retiring physicians in the next 10 years is expected to be around 400,000 people that will retire. So if you look at these numbers in medical specialties, because that's the area where I specialize, about 46% of our population is represented by Medicare patients. But that number is expected to increase in 2033 to about 55%. But once again, the number of physicians that will retire is 400K in the next 10 years. So the question is, who's going to take care of these patients? If you are a resident, or if you are ready to apply to become a resident, you have to be supported by the graduate medical education programs, which are also in majority of time supported by Medicare. I will tell you about a survey that was done in 2021, and unfortunately there were about 38,000 positions, but much more applicants than the number of positions, about 48,000. And those numbers of people that they graduate, they will remain without the position because there is not enough matching spots for this graduating physician. And that is because in 1997, Medicare, with the Balanced Budget Act, put a cap on the number of residents that they could support every year. Only in 2021, they increased this number from 90,000 each year with 1,000 new Medicare-funded GME positions. Is that enough? No. And unfortunately, after you graduate, there will be more limitations placed by the medical boards, which have to license you in each state where you want to practice. And every license is very expensive, but not only that you're going to apply to receive the license, but every 2 years, you have to renew this license. And despite the fact that there were some temporary limitations raised during the pandemic, now they are coming back to the old requirements to be licensed in all the states that you are trying to practice. And things in terms of reimbursement did not look any better because Medicare started to decrease the reimbursement of the services. And although this is a study that applies to emergency medicine, that applies to all the specialties. So over the last 20 years, the reimbursement decreased with about 30%. And that was after adjusting for inflation. But if you look at the value of the dollar in 2000 compared to 2021, that decreased to about 60%. And what's happening, and without the intention to scare you, but we, the physicians that are practicing, we do experience what we call burnout. A lot of physicians in their practices, they do experience this feeling of burnout. And burnout results in medical errors, lower quality of care, higher costs, and overall worse outcome. And burnout is not a physician problem. It is not an individual problem. It's actually a system problem that needs to be addressed very quickly. Unfortunately, for residents, in the first year, about 60% of them, they will start showing depressive symptoms. And that is across all specialties. Over the course of training, between 20 and 43% of residents reported depressive symptoms. And what's very, very sad is that the number of physicians that die every year by suicide is estimated to be about 300. And those rates are expected to rise. So what will be the option? Is direct care an option? Are we reinventing the wheel? Actually, no, because direct care used to be here but it changed over the last 20, 30 years dramatically. I'm going to talk to you about rheumatology, the specialty where I am practicing. This is a specialty where we have low supply by high demand. There is a huge shortage of rheumatologists in the United States. And as I mentioned before, the waiting time in rheumatology is between 4 and 6 months. And that is happening if you live on the East Coast or on the West Coast. If you live in other parts of the United States, that wait could be even longer. And unfortunately, the number of patients with arthritis, and this graph will depict just arthritis, is rising. If in 2015 there were about 54 million with arthritis, in 2040 it is expected to rise to 78 million. So those people will need someone to take care of them. And this graph does not count on people that have autoimmune diseases, which is also rising. Those people need second opinions. They need to have treatment monitoring. So I started my practice with the goal to broaden access to a specialty that is rare, and not only give patients the ability to come in an office and be limited to a location, but give patients the ability to be seen from wherever they are in those US states where I'm practicing at this point. So just to point a few differences between my practice and the traditional healthcare, in my practice, the time to consultation, it's less than a week in most of the times. The time that the patient spends with me, it's about 60 minutes. And if you compare to 7 to 15 minutes in the traditional healthcare, that makes a huge difference for patients, because in this time, you have the time to address their needs, and the patient feels listened, and he has the time to address his concerns. There is direct communication with the physician in my practice. And on the other hand, in the traditional healthcare system, you have to wait on the phone or send an email, which will be taken by a nurse, and it doesn't get to the physician until later on. I do accept all people. I do not want to discriminate based on their insurance. I work with people with all insurances, but they have the option to take the invoice and discount that. If you are contracted with certain insurances, you have to see just those patients that you have a contract. So that doesn't apply in my practice. If you don't have an insurance, it doesn't matter, because I'm still gonna see you. Again, I'm not discriminating based on that. And if you have an urgent visit, because I have a smaller panel of people that I see every day, I can accommodate and I can see an urgent visit in the same day or the next day. What's happening in the traditional system, when a patient has an emergency, he is sent most of the time to the emergency room or to an urgent care. I do disclose very clearly all the prices for the consultation, for the labs, for the imaging, and those are not only disclosed, but are very discounted prices for labs and imaging. In the traditional system, besides the fact that you know that you're going to pay a copayment, you have no idea how much you're going to pay after that. And most of the time you end up with a huge bill for the labs or imaging, or you're going to end up with a huge bill for a consultation that was partially covered. So I will tell you a story of one of the patients that came to me to be evaluated for an autoimmune disease. After talking to the patient, I made an assessment, and I was able to discount all the labs that he had to do to 150, to discount the imaging that he had to about $1,400, and the medication that he needed to about $100. So the cost of his consultation with everything that he needed was about $2,000. But in the traditional system, because the patient had a high deductible, so he was very interested to find out what are his options before he pays his deductible. In the traditional system, the same cost of labs, imaging, and medication will raise the cost of his care to about $7,000, between $7,000 and $13,000. And again, that is usually the price of consultation after you need an evaluation for an autoimmune disease. Now, I want you to think about big, multiply those numbers with 52 million arthritis patients or 23 million autoimmune diseases, and the cost, or the savings in cost will be tremendous when you think about those numbers. And like me, in the last 2 years, I was able to identify people that started to work in direct specialty care. I just put a couple of the people that I was able to connect over the last 2 years, and they are specialists from cardiology, rheumatology, podiatry, ENT. There are specialists in endocrinology or cardiology again, or radiology, that they started to work in direct specialty care. So our thoughts after numerous discussions were that it's going to be better if we scale up this movement, this direct specialty care movement. And the goal, the goal will be to become or to see more physicians independent. When we thought about the values, we always consider the patient should be first. We should offer transparency in our costs. We should be accountable to the patient as the patient is accountable to us, and we should remain accessible and independent. So we've started this alliance. It's called Direct Specialty Care Alliance, with the purpose to serve our patients and help each other to grow in this space. And our goal is to be known and to be able to help the direct primary care movement and whoever needs our services. So the mission was to lead, or is to lead, the movement of specialist physicians in becoming independent and be able to provide direct care services to patients. We want to provide guidance to those specialists that they want to become independent, and they want to partner with their patients to provide the highest level of quality care to accessible and transparent cost. So there are many things that we need to figure out in our space, and we have many dots that we will need to connect, but we are there, and we started to see more and more specialists coming in the direct care in the United States. We put together a map that will be very soon available for patients to find us and to get the services that they need to an accessible and transparent cost. So this is going to become a community for direct specialty physicians. We will be able to educate others. It's going to be available for patients that are interested in free market. It's going to be available for you, the residents or the medical students that are interested in this movement. And we're going to make our services available to self-insured employers. And those will be some of the advantages that we foresee through this alliance. And I would like to thank you very much. And I would say that I'm very honored to give the presentation to medical students, because I know, like you, I was there, and I never thought I'm gonna become a specialist, but time will pass and you will get here. Thank you so much, and I'm very happy to take questions.
Thank you so much. You said a lot of things for me that were very exciting, especially about the alliance. I mean, I learned a lot more than I knew. I know a lot of the people on your list, on your chart. I know a lot of them. I'm familiar with them and have had the opportunity to meet a lot of them, and we've spoken to quite a few of them on this virtual series. For you, one of the questions that came in a couple of times from students was, what was the most difficult part about setting up your own practice? I mean, you have it in two ways. You have not only a direct care practice, a direct care specialty practice, but also telemedicine. So, just talking specifically about what you do, what were some of your challenges?
So the biggest challenge was to figure out how to open a practice that could be functional in multiple states. That was the biggest, legal challenge that I had. To form a company that will serve patients in multiple states, not many lawyers knew about this possibility. And that discussion took about 6 months with multiple people to figure out how to form this company, what kind of legal structure will be there to be able to serve this. And then licensing in all these states took forever. Every state is different in their requirements, and every state will process your license differently. And I will give you an example. California and Texas, it took between 9 months and 12 months to give me a license. But there are other states like Montana, for example, they give me the license in 2 months. So it differs very, very much. So you have to plan on these things. The other thing, a very challenging thing, is how to promote your practice to people, how people will be able to find out about you. So the route that I took was to introduce myself to the direct primary care community. I knew they are eager to find specialists because what's happening most of the time, the patients, after they are seen by a direct primary care physician, if they need a specialist, because of the lack of specialties in direct care, they would have to send them to the traditional system. So every saving that they did before doesn't always, it's not going to count, because they're going to go back in the traditional system and they're going to be treated the same and the cost will be the same. So the advertising part was very challenging in the beginning. But once people found out and they experienced the quality of the services, then it's like the word of mouth. People will talk about you and will start presenting your practice as a viable option when you don't have any other option. This is there, and if you need it, you have that option. I'm going to give you the story of a patient that lives here in Sacramento. She was able, theoretically, to see a specialist or a lot of specialists in her area. But when she needed to see one, she was unable to see a rheumatologist for 6 months. So her primary care physician, which was a direct primary care physician, he reached out to me to figure out if I'm able to see her. I talked to him, I helped him, I saw the patient the next day. I was able to, offer her the plan, the costs, everything. And she was amazed because, on the other hand, she had this high deductible and she was trying to find a way to get to the specialist, but she was also putting together how much it's going to be if she pays for her care. And the savings were, again, incredible. And this is a challenge. The other challenge was to find contracts, direct contracts with labs or imaging centers, because when you are by yourself in the beginning, nobody is going to open the door. So you have to knock on the door multiple times until they open the door for you.
That was one of the questions. To know me is to know that one of my soapboxes that I go pretty high up on is the lack of business knowledge that medical students receive and then come out of medical school with. When you were looking for the partners, those people that, the labs and the MRI centers, all of those things that you might need, how did you go about doing that? And the second question, and this would be mine, where did you get the business knowledge to do all these things?
I learned. I took a few online courses, and then I bought a lot of books, and I started to read and try to understand myself what is the difference between an LLC, a corporation, things that you can do in terms of legal structures. I learned myself about those, and I started to ask people questions. So every single person that I've met, I would ask not only questions about not medical questions, but I will also ask business questions. And in the beginning, it's kind of weird because you realize how much you don't know, but with time and, putting a little bit of investment there, I think you learn very fast. That's how we are. We learn if we are able to learn, anatomy and biochemistry, and if we are able to learn all the pharmacology, we are able to learn business as well. But I feel like it's a huge need for people to, like people in medical field, to invest time in understanding finances and understanding and developing some taste for a business type of. I think this needs to be part of our education. It's crucial to understand. Understand what you are doing.
I think it's I personally, I feel it's I feel like we're doing our medical community, our physicians, but all of our healthcare, a huge disservice by not providing some kind of business knowledge in school, because you come out and you're expected to sign contracts. You have enormous debt for the most part, and you don't know how to, what to do next. But for those of you that are starting practices or going into practices, what does this mean for your life and how to navigate that? Not having that business, that education, I just feel it's an entire disservice to you. So I think it's great that you said that you did this, that you found a way to educate yourself. I think that's very important for the students to hear. So you mentioned that your patient in the Sacramento area was with a direct primary care physician, a practice. Is that something that, so the Alliance has their specialists? Do you work a lot with direct primary care physicians?
We started to work. I mean, myself, I do offer them two types of services: the traditional consultation when they need that, but I also offer them the peer-to-peer consultation. That means that if they have a patient that they don't know if they need the specialist or not, or there might be something that they can handle at their level and save money for the patient, they can pick up the phone and present the case to me, and I will be able to direct them towards what workup they need or what medication they can try. So the patient doesn't necessarily have to come to me to be able to do that. Or on the other hand, instead of sending the patient to me directly without the proper workup, and then it's going to take me 2 more appointments to do that proper workup, I will tell you these are the things that I would order in this situation. So when the patient comes to me, we have everything ready. We have the workup, we have the imaging. I just have to talk to the patient and put a plan in place, which saves them money and saves them a ton of time. They don't have to wait until they see me and then wait until the labs are done. So we speed up the process of care tremendously. And I know primary care physicians, they love that, because many times they have a question for, autoimmune labs, and they think about it like, what should I do now? What should I order? So they have that flexibility to, discuss with the patient. Look, there is a physician here, a specialist who can educate us about what you do, what we should do. And the patient understands that, and it's going to give the agreement to the doctor to discuss the case with me. They pay a fraction of the cost that they will pay for a consultation, and they have this care streamlined. So that's the type of service that I offer.
I'm sitting here kind of dumbfounded, because actually having that peer-to-peer connection, it's continuum of care that we don't see outside of what you're talking about. I mean, I'm a mom of 3 kids, and having that ability, one of my children has a lot of pulmonology, she sees a pulmonologist quite frequently, and being able to have that kind of care and that continuum of care would have been so welcome in what we have faced. And I find that huge in what you're offering to your patients. I'm sure they do too. What kind of feedback have you received on that?
They love it. I mean, patients, they like the idea not to spend a lot of money to see me, to do that kind of workup. And they love the fact that their primary care is in the middle. He knows the patients the best, so they can present their case much better, sometimes much better than they can present their own case.
Yeah.
And on the other hand, through this alliance, we are trying to develop this kind of networking, a connection between us, the specialists. And if I have a case, and I had that situation, I had a case in Texas, okay? I'm in California, but the case was in Texas. And I was able to communicate with the ENT physician of this patient. So we put together a plan for the patient that she was able to implement there. She was actually the one who wanted me to see the patient. But before the patient got to me, we had this conversation in the beginning. We did the workup for the patient. And then the patient came to me. And after the patient saw me, I was transitioning back the patient to her, and she was able to do a surgery on the patient. So this kind of networking that doesn't have the limitation of a location, I feel like it's mind-blowing for a physician. I don't think we should be limited. Our knowledge and our scope of practice should not be limited to one location or one area of 10 miles, of 20 miles, of 50 miles. If we can give our knowledge, 1,000 miles away, we should give it. We should help the patient from 1,000 miles away. I think that kind of communication and networking between us it's crucial.
One of our students said that one of the slides that you showed was talking about COVID and what the restrictions were, how they were relaxed during COVID, but they're coming back now. Do you, for your practice, but also other practices as well, what do you think what do you think is going to be the biggest challenges coming back, or maybe over the next year or so?
If you are fully licensed in those states where you want to practice, there is not a problem. But if you are, there are some states, for example, Florida or North Carolina or Nevada, that they do allow you to have just a telemedicine license. So if your license in other states is in good standards, you can apply just for a telemedicine license, but that's a temporary license and it's a partial license. But if those requirements or this permissive times will go away, then you have to apply for a full license, and that will not be a problem.
So it's decreasing that access into those states as this goes forward. Going back to what you just said, that it shouldn't be limited by your distance away.
Yeah. What is very, very challenging for me to understand is that we do train based on the same criteria. We do train and we do pass medical boards that are nationwide. The exam is nationwide. So the same level of knowledge that is tested applies to all of us. But despite that, we have to license to certain states where we want to practice. And that is very restricting the scope of our practice. And I understand they want to protect the patients, but on the other hand, they limit the ability of people's, like physicians' knowledge to be given away to people that they are in need. And I'm going to tell you, there are many, many patients from all over the United States that they reach out to me trying to get help. Unfortunately, I'm not licensed in all the 50 states, and I don't think I will ever be licensed in 50 states. But there might be other people that will start to see patients in the states where I'm not licensed. So the purpose of this alliance is to identify those people. And there are now more rheumatologists that are coming along and they want to do this. They're reaching out to us to get help, to find a way to start their practices in direct care space.
So I have a second year student that is actually interested in possibly doing rheumatology. And he says, what would be if he wanted to actually practice doing telemedicine someday, what would be some additions to his current training that he might need to look into?
I think there are not much additional training that is required. It's not required to be, licensed in telemedicine. There is not such a requirement, but you should know the basics and you should be comfortable about what you can treat and what you cannot treat. So you need a few years of practice, like hands-on practice, to be able to have that comfortable feeling, to know when a patient can be seen virtual and cannot be seen virtual. There are situations when I have to send the patient to a local rheumatologist. Many times I pick up the phone and I find one for the patient. But if the patient is stable, if the patient needs treatment monitoring, or if the patient needs, let's say, just a second opinion, which happens many times in rheumatology, then you can see the patient without any problems on telemedicine. I know there are people that don't believe in telemedicine, but on the other hand, we have this technology. We should use it. And like we are doing banking and shopping and everything on our phones, we should do, or we should ask for a medical advice on telemedicine. We should not be afraid to use technology.
I'm wondering if the pandemic has changed that perception. I'd be interested to see, and I haven't seen, it doesn't mean it hasn't happened. I'd be interested to see if the public has changed their perception of healthcare through telemedicine, because so many of us used it. Even if we've never used it before, so many of us had to over the past 2 years. And I'm wondering if there might be if that might be the way in for more specialists. And, we had the same question for direct primary care about the increase in training, because there are things, there's things like using specific pieces of technology that go into a computer that 2 years ago, it was normal for a direct primary care doctor to be using that kind of technology, or to at least be looking at it. But for people that weren't doing telemedicine, they didn't see it necessary. Now I think everybody sees the necessity of looking into technology that can at least be used in telemedicine a little bit more. So I think that's I think it goes beyond a rheumatology question, beyond direct primary care, but into just everything more. What is that technology going to look like? So
I think that, millennials and people that are younger than millennials are very ready for telemedicine. There are a special category of people that are not ready, and I don't think they will be ever ready, but you will be surprised that even elderly people will reach out to me via telemedicine. Yes, the pandemic kind of speed up the things in the traditional system. And to be sincere with you, before the pandemic, there was no way to bill for telemedicine. So that's why the interest was not there. But there were centers even for rheumatology, like in Alaska or Dartmouth, that they were doing telemedicine before the pandemic. And there were a few, I think 1 or 2 rheumatologists across the country that were still doing telemedicine. Patients love it. Patients that they feel stable, they just have to see you for treatment monitoring. They don't have to travel. And I will give you an example of one of my patients. She was supposed to travel an hour and a half to come to see me in the office, and then waiting in the office for another 30 minutes, see me for 5 minutes the most, and then travel back an hour and a half. Now she calls me, and we do have half an hour to discuss all her concerns, but she sits comfortable in her house.
Yeah.
And she loves that convenience. I think telemedicine brings on convenience. And if we can add to this convenience the access, you don't have to again, travel, pay someone to take care of your kids when you are away, or take time from work. That kind of speed up access, it's something that people will look to have. They will not want to go back to the old days.
So a student that wasn't able to be on with us live today, but is very interested in rheumatology, but is also interested in rural medicine. Something it's very important to her. She wonders if something like what you're doing and doing specialty care via telemedicine, and I don't know if this is something that you've thought about, is something that could be utilized or should be utilized or has been utilized in rural medicine, because with all of these hospitals closing, it's limiting what specialty care is available, and we need to address this.
Yes, I have many patients from rural areas. They are the ones that they need the most. As I was telling you, if you live on the East Coast, close to a big city, or on the West Coast, close to a big city, you're going to have options. Even if you wait for 6 months, you're going to have options. But if you live in the middle of the United States or the south of part of the United States, there is huge needs of specialists there. And those people, they suffer or they delay care, and they end up with huge medical problems because they don't have access. So that kind of medicine, this kind of medicine, telemedicine, and specialists in telemedicine, it's going to be something that will solve, if not the problem, many situations that could become dramatic over time.
Yeah, and it's frightening the way that big hospitals and big healthcare systems are taking, when they eat up these rural hospitals, or even cut the finances to them because they're eating them up. The first things to go are the specialty care. So whether it's OBGYN or it's rheumatology, it's these specialists that they're so desperately needed, and we need to figure out ways, and it feels like telemedicine is the perfect way to do it, to get this vital, it's crucial care to these communities. So I think it's heartening to know that that's one of the things that you're providing through the telemedicine, but also the other specialists that are doing what you do, because that $2,000 to $4,000 deductible, you can't do. Most of America they can't do it, and this is a way that we can help provide that. That is my last question, I think. I'm looking through everything. I'm going to be able to share Dr. Girnita's information. I really hope that everyone here goes and checks out the Alliance, because it's fundamental to, it's one of our partners. It's part of the alliances that we belong to as Benjamin Rush Institute. It's organizations like this that are coming up and popping up and showing how much what this network that we're a part of, it's growing. And this is what it's so heartening to myself and to what we're doing at Benjamin Rush Institute, that these alternatives to healthcare, the education that we're providing, it is getting noticed, and people like you, our students, you do have other ways to practice medicine. The most vital thing is that burnout rate and that suicide rate. Don't give into it. You can practice medicine that you want to practice, that you can affect that doctor-patient relationship. It's up to you to understand that, and to help your peers understand that when you reach out to them and talk to them, and point them in the right direction, because all of these wonderful people that are part of this alliance and the other groups that we talk about, they're going to want to talk to you. They're going to want to help lead you in the right direction, because they do care. So get in touch with them. I will share Dr. Girnita's information. If you are a supporter, please, get in touch with Dr. Girnita, but also the other people that are part of the Alliance. If you are looking for, direct care that isn't part of those, the big that I talk about, that, the big insurance, the big pharmaceutical, the big hospital systems, you're going to get better care and you're going to be able to influence your own healthcare, which is so important. Dr. Girnita, is there anything else you would like to say before we close?
First of all, I want to thank you for educating young souls that are entering in their career. Education is part of my goal in everything I do. Myself, I have educated many residents that actually pursue rheumatology after they rotated with me. I'm still keeping an academic position this is done also to educate young people like medical students and residents to pursue a specialty like rheumatology. I'm very passionate about rheumatology, but I'm also passionate to help other physicians that they feel like they can do more. They enter into medicine to provide medical care. And I want to tell patients also that if they want to support us, they are very welcome in joining us and sending us messages and sending stories that they have experienced with us, because that's the most important thing, to be heard. And patients should be heard. Patients that share their experience with a direct care practice, and they have, not a single patient I hear talking not like superlatives for us. They talk so highly about what we do, and they understand that we are just a small wheel in the traditional system, but they don't know how to help us. So in order to help us, they should share the stories with direct specialty care physicians, and there is hope. There is big hope, and that you can practice back medicine, and you should be happy again with your choice. Thank you so much.
Thank you. I love that you can be happy with your choice, because there are so many people that are like, why would you ever want to go into medicine? And this is the reason, be happy with your choice, and that you can practice medicine the way you want it. You've wanted to for a long time. So I thank you. I thank you for your leadership. We need more people like you and your colleagues that are doing just remarkable things. I think it's brave. And I do encourage others to reach out, but to also take the leadership position that you're taking. Thank you so much. We will be putting this recording up on our YouTube channel in just a few days. I really welcome you to look at our YouTube channel, subscribe to it, so you're notified when we put up new videos. If you're not a subscriber to our newsletter, go to benjaminrushinstitute.org so you're notified of when we put up wonderful new information, including when our next virtual event series is going to be. If you are a student and are not yet part of a Benjamin Rush Institute chapter, get in touch with me, Rebecca at benjaminrushinstitute.org. And I will be sending out Dr. Girnita's contact information to everyone who's registered. So Dr. Girnita, thank you so much. It was such a pleasure to see you again. Thank you for coming on today, and thank you everybody for joining us. I appreciate it.
Have a wonderful day.